I would like to start with an apology rather than thanks, because I'm really thankful to be given the opportunity to come and be part of this. But the apology is because I should have had this lecture yesterday along with the other topics on the spinal cord injury. And because I had something else to do, I requested Mrinal to change the date, and he very kindly did so. So if you'll have to do a little pivot shift, you have to go back to yesterday in your mind, so that because a lot of the things that were said yesterday that pertain to this, like the connection between the bowel and the bladder and autonomic dysreflexia, etc., I will not be dealing with today. But thank you very much, Mrinal, Venu, and the foundation for inviting me. You know, I'm quite an old man, and people have found that you can take Surjan out of rehab, but it's very hard to take rehab out of Surjan. So here I am back again, very excited about this opportunity to talk to you about the neurogenic bladder, and of course listen to all the other lectures. The previous lecture was, as ever, enlightening and exciting. Thank you so much. So, is there anyone in the room who does not or has not treated the neurogenic bladder? So all of you have treated the neurogenic bladder. That's good. So I can take a lot for granted. For this half an hour, I thought that we look at bladder neurophysiology. There are lots of new science there, and look at the classifications of the neurogenic bladder, and review the evaluation and look at management strategies. The brain, spinal cord, bladder pathways have been known for a long time. What is new are the new molecular receptors that are being described in larger and larger numbers, and their magical functions. Of course, the sympathetic nervous system, if I would summarize it, controls the storage function of the bladder, and the parasympathetic, the voiding function, and the somatic, the voluntary sphincter control. Here's a picture to remind you about the receptors, and so here's the parasympathetic nerve, the pelvic nerve, and the main receptor is a M3 receptor, muscarinic 3, and the neurotransmitter is acetylcholine. Here's the hypogastric nerve, bringing the sympathetic nervous system to control the bladder. It has two components. It is a beta 3 receptor in the detrusor, and in the bladder neck and in the proximal urethra there are alpha receptors. So obviously they do different things. This one produces helps with the storage function of the bladder by relaxing the detrusor, and this increases the storage function by making it harder for the urine to come out. That's by closing the sphincter. And of course, the somatic sensations and the control come through the pudendal nerve. It's again acetylcholine, it's a nicotinic receptor, and this is part of the urogenital diaphragm. Just to remind you again of the storage and the voiding reflexes, and to remind you of the importance of the pontine storage center and the pontine micturition center, and of course the PRG as well. You know, these are all important supraspinal controls which come into play particularly in diseases of the brain, and many patients who may come to you with a spinal cord injury may also have other problems like a head injury or a stroke, and they will have bladder problems because there are supraspinal controls as well. To summarize, here's the storage function, the receptors, and when the bladder is not very distended, it sends signals, afferent signals through the pelvic nerve, and part of it goes to the T12 L1-2 spinal segment where the sympathetic nervous system neurons are located, and they inhibit the detrusor. And some portion of that also goes to the pudendal nerve, and that through that it actually makes the sphincter contract, and thereby bladder storage occurs. Don't forget that the pontine storage center also sends signals to the pudendal nerve cell bodies to increase the external urethral sphincter tone. On the other hand, when voiding has to occur, there are the stretch receptors in the bladder. They actually respond differently. When these are stimulated excessively or beyond a particular threshold, they actually cause the sympathetic system to become diminished, so that the inhibition to the detrusor is diminished, and they work through the voiding center to activate the S1, 2, 3 centers for the parasympathetic system, and that produces a detrusor contraction and inhibits the sphincter, so that the sphincter relaxes, detrusor contracts, and voiding occurs. And of course, we'll soon be coming to abnormalities when this does not happen smoothly and you get DSD. And when this doesn't happen very well, and you can get an overactive bladder. I'm sorry, I meant to put a timer for myself and I forgot. So here's an overview of the various pharmacological agents that are required or that act in controlling the bladder. And I've just been through this already, so I won't go through it again, except to remind you about these P2X, 1 to 2, actually there are 1 to 7 receptors, which are in the urothelium cell, in the detrusor muscle cell, and they can be activated, say, in infections. They can be activated in, when there are drugs that are in the bladder, and it's really important to remember them. The next slide is to remind you about the pathophysiology of the neurogenic bladder. Of course, this is the normal bladder, and here is a suprasacral lesion, which causes the sympathetic and the parasympathetics to lose their control from the pons and the brain, and therefore there's overactivity, and there can be uncoordinated activity between the detrusor contraction and the sphincter, and so you can get DSD. And of course, if you get a sacral lesion, often the sympathetic system is not involved, and so then you can get a atonic bladder, and there may be various levels of tone in the sphincter. So you'll usually get a bladder that is flaccid and fills excessively and is unable to contract and evacuate the urine. So much for a very brief allusion to the neurophysiology. The classification of the neurogenic bladder, there are many kinds of classification, of course, by the neurological level, as we just saw, by urodynamic behavior, overactive, underactive, and areflexive, and by clinical staging, that is bladder storage dysfunction or bladder voiding dysfunction. These are important because if you have, if you're just making a clinical diagnosis, you would perhaps just through history come to a decision what kind of a problem it is. If you did a neurological examination, you would be able to locate the site of the lesion or the sites of the lesion, and using urodynamic you'd be even more effective, because there about 60% of the time there is poor correlation between the neurologic lesion and the urodynamic behavior, because the muscle itself can be overstretched and damaged, and there can be problems in the urothelium. So here's a very brief classification: suprapontine, suprasacral, and peripheral. I just put this in because I wanted to remind you that CORDA and diabetes and other peripheral neuritis, neuropathies can also produce an areflexive underactive bladder. When I was much younger, syphilis was common, and tabes dorsalis would also do that. We hardly ever see that now. And So the next one is just to again remind you that spinal cord injury is not the only thing that produces a neurogenic bladder. You can get it in multiple sclerosis, Parkinsonism, spina bifida, etc. Now the clinical features, it's important to take a good bladder and micturition history, and asking them questions about how long it takes for them to start micturition after they start, if there's any hesitancy, if there's any frequency, is really important. And by asking that, you might be able to find out, that their urgency is actually an overflow incontinence, and their hesitancy may be from the prostate being enlarged and the sphincter being less effective because the median lobe of the prostate is sticking in there. It's also important in the neurogenic bladder to always check for complications. You might have a person who has had a spinal cord injury yesterday, but he only has one kidney, or he's got multiple ureters, and so he's already predisposed to damage to the urinary system. And if the earlier you know it, the more carefully you can factor that in the management of this patient. Now, physical and neurological exam is critical. It's really, really important to assess the sacral reflexes and the perineal sensation. And it's not easy to do it in a dark room or in a ward where the lighting is poor. So we in CMC would often take them to the cystoscopy room and where there's good light and check for these reflexes there. I'm only saying this because if the reflex is present strongly, you can see it, from a mile away. But sometimes it's just coming back, and you'll see a little flicker. Imagine you're checking the strength of a muscle, and you're looking for a flicker. You would expose the whole muscle and look very carefully. So, particularly, there may be changes in these reflexes during the course of the treatment of the person with spinal injury, and therefore I feel it's really important for you to examine these carefully. And as ever, the voluntary power on the toes gives you a good idea of what the S23 or L5S23 segments are doing, and therefore I particularly look for that. And remember that the person's cognition, hand functions, sitting balance, standing balance, all these will make a difference to how he can actually take care of his excretory functions, and therefore they are part of the neurological exam. And as I've already said, serial follow-up is really important to track these changes. This is not, I'm sure that you remember the cutaneous supply of the nerves and the segments, but I put this slide up because I want to remind you that the cremastic reflex is has the same segments as the sympathetic nervous system, and the bulbocavernosus has the same root value as the parasympathetic nervous system. The knee reflex, the ankle reflex, and the anal reflex is also there. This is just to remind you that by doing all these 5 reflexes, not just the cremastic and the bulbocavernosus, you'll get a good idea of what's happening there, because the somatic reflexes will tell you what's happening to the somatic neurons, and the other reflexes will tell you a little bit more about both the sensory and the motor components of these reflexes. Now, investigations, of course, these are all commonly done. A urinalysis. I just want to mention that looking for pus cells in the urine in a person with a neurogenic bladder, it's not a good positive predictor of infection. There may be lots of pus cells and no infection, but it's a good negative predictor. So if there are no pus cells, it might give you a clue. Of course, it's a good screening test. It's not a good diagnostic test. Renal and bladder ultrasound have replaced more or less IVP for examining the neurogenic bladder, unless you've got calculi or you're suspecting blockages in the ureters. And urodynamic studies have become more and more important in treating these patients, particularly if you want to make them continent. Cystoscopies has specific indications if they are having difficulty in the urethra with catheterization, if there's blood in the urine, or if there are stones and you want to fish out the stones, etc. I just thought that the thing that I could do for you today is to spend a little time on urodynamics. And this is from Nature Reviews, and this is the urodynamic. It's a video fluoroscopic urodynamic study in a normal individual. So here's the graphs, and these are the fluoroscopic pictures. The bladder is empty, it gradually fills, and then there's a voiding study. And this is the flow. There's no flow till the patient voids. And here's the cough test. So this is in the abdomen, and in the vesicle, and this is the subtracted value, which is the detrusor, and this is the probe in the urethra. So as the bladder is filling, this is time down here. The detrusor pressure is not going up. The urethral pressure stays high. The patient is continent. When he wants to void, the detrusor pressure goes up. You can see the abdominal pressures also go up, and the urethral pressure comes down, and he voids. And here's the amount he voids. Of course, there's the first sense of fullness, and then there's, excuse me. I'm leaning on the computer. Sorry. There's the first sense of fullness. There's the first desire to void, and there's a strong desire to void. And so this is how a full fluoroscopic urodynamic study would be done. Now, we are lucky because we have actually, Dr. Rajdeep has developed a low-cost urodynamic system in CMC, and now we are able to do these routinely. We did have a full urodynamic set. It lasted for 10 years and faded, and we are still saving money to buy the next one. But in the meantime, what he's developed is really very useful, and I wanted to tell you about it. When it goes into production, I think it'll cost only a few tens of thousands, maybe 10 or 20,000, I don't know how much. But I wanted to show you how useful it is. It doesn't do the full urodynamic studies, but it gives us a lot of information. So here's the urodynamic study report of a 45-year-old female patient with a T12 Asia A paraplegia since the 9th of December 1998. She had been on indwelling catheter for her left ischial sore, and then developed fever, and so she came in for the fever. You'll notice all these were done during our rehab mela. Therefore, they were all done on the 16th of February last year, when we were trying out this urodynamic system. And so you can see that we filled the bladder, and the capacity was about 111 ml, and she leaked at about 56 ml, and the maximum detrusor pressure, that's the detrusor pressure, was about 56 centimeters. So it's a small volume bladder, and it's overactive. Okay, we don't expect it to go up to 56 centimeters with only 112 ml of fluid in it. If you look at the next urodynamic study, this is of a 36-year-old female patient with a traumatic T8 Asia A paraplegia from a wall collapse. Forgive the 3 L's, it must have been a big wall. On the 27th of February 2011. Again, you can see the filling, and this is the vesicles probe. This is the abdominal probe, or in the rectum, and this is the subtracted detrusor report. Again, you can see the systometric capacity is 282 ml, and the maximum detrusor pressure is only 6.2. See, it doesn't really go up, although the bladder is filling. So the impression is that this is obviously an A-reflexive detrusor. Notice that she has a T8 traumatic paraplegia, and you wouldn't expect an A-reflexive detrusor. But the injury occurred in 2011. Did she do an Iwatsubo procedure on herself by over-distending it and destroying the Meissner's plexus in the bladder? Or does she have a lesion that, although it was a T8 injury, did she actually have a syringomyelia, or was the bladder injury much more extensive than what was initially diagnosed? So this was just to show you that there can be a disassociation between the level where you expect it to be a spastic bladder, and it isn't. Here's a third patient. He's a 43-year-old farmer with a traumatic T6 Asia paraplegia. And here you can see it's a spastic bladder or a overactive neurogenic bladder. As the bladder is filling, the infused volume is about 350. You can see that the pressure is going up and there are spikes of detrusor activity. And so this is a poor compliant bladder because with increase in volume early on, the pressures are going up, and he's leaking. So this is a neurogenic bladder overactivity with poor compliance. This is the urodynamic report of a 23-year-old male with a traumatic L2 Asia C paraplegia since 2019. Here again, as the bladder is being filled, after 100 ml, he begins, there's a reflex voiding, and we didn't use a flow meter here to see how much urine came out, but the pressure has gone up to about 160 centimeters of water. So again, this is a neurogenic detrusor overactive bladder, and when the average pressure is above 40 centimeters of water, there's a risk of those pressures producing hydronephrosis and renal damage. And momentary rises like this are not as bad as a continuous average pressure above 40 to 60 centimeters of water. So that's what we're looking for. This is the urodynamic study of a 7-year-old child who had a traumatic T4 paraplegia, Asia A, following a road traffic accident more recently. And this I chose to show you because no infusion was required. The probe was put in and we immediately noticed that there were spikes of increased pressure. So this is an unstable detrusor and there's overactivity. So we didn't bother to infuse because we got the diagnosis that we wanted. He's got a neurogenic overactive bladder. The last one is a 31-year-old male patient. We've known him from the time he was born. So we've been following him up for 31 years. He had an L3 meningomyelocele, but his upper tracts are fine. He continues to leak, and so we usually check to make sure he doesn't have an infection. And since he had come for the mailer, we also did this urodynamic study, and you can see that as his volume is increasing, the detrusor pressure is rising, but that's 20. Okay, you have to keep looking at the values on the left. These values are being changed according to the range that is required for the study. So the average value does not go above maybe 10 or 15 here, but it says 16 centimeters of water. So he's got a bladder which is compliant. It's not actually, the pressures are not shooting up as you fill it. The detrusor pressure is staying low, and we were able to fill it with 300 ml of water or saline. So I just took a spattering of urodynamics to give you an idea of how good it is to make your patient continent and safe if you have these urodynamics pressure studies done. Of course, the goals of management are undisputed. We have to preserve renal function, which is the primary goal, ensure safe bladder emptying and improve continence and quality of life, and minimize infections and complications. Depending on the kind of bladder that you get, you would, for incomplete bladders, incomplete lesions who've got some voluntary control, we would try timed voiding, try to make sure that their drinking is paced out so that they're not drinking too much. And if they have voluntary control, we would try pelvic floor exercises, and many of them during the training period would require incontinence devices, convenes, or sort of homemade convenes. But if they've got a neurogenic bladder with no voluntary control, in the old days we used to try to do what was called reflex voiding for upper motor neuron bladders, and we would try to reduce the bladder neck pressures by doing surgery, bladder neck incisions, bladder neck resections. But since then, times have changed, and I just put this out mostly for historical interest. For lower motor neuron bladders, we still use Crides or Valsalvas, and external incontinence devices are with us. I just want to spend a little time going over catheterization options. I think that there's one paper I'd like you to read if you haven't already, and that is Jack Lepidis's paper on clean intermittent self-catheterization for urinary tract disease. It was published in 1972. It's one of those classics that I feel that you must read, because he didn't have urodynamics, he didn't have any of the wonderful things we have now, but he came to absolutely sensible conditions. And I would tell you the story, except that I think I'll run out of time if I will. So when I meet you, I will tell you the story. How he had a patient whom he had put on sterile intermittent catheterization, but she had a mental problem. So she came back many years later, and she was fine. And he asked her, how did you manage to stay fine? Where were you getting the money to buy all these sterile catheters? He found out that she was just using that one catheter. She fished it out of her bag, showed him how she was using it, and she was fine. So then he suddenly realized maybe we don't have to use sterile catheters, and then that's how clean intermittent catheterizations came to be. There are 5 really or 6 really important things for you to remember if you want clean intermittent catheterization to work. I'll tell you another story to help you remember it. Just 2 weeks ago, when I was thinking about what I should share with you, I was sitting in the Chittoor campus OPD, and a slightly, 60-year-old gentleman came to me and said, "Sir, do you remember me?" So of course I had to confess I couldn't remember him from Adam. He said, "I'm Stanley, your patient from 1987. Matthew may remember him. He had, sorry? No, he was a T12 fracture spine, and he said that you rehabilitated me and he taught me intermittent catheterization. I was working in the State Bank of India in Bagayam. But he said, I didn't tell you I was depressed, so Dr. Anatharian also treated me, and my depression is also lifted now. But so I said, so how is it going? He walked in, so he had obviously recovered from his motor and sensory, somatic motor and sensory loss. So he said, no, I do the intermittent catheterization. I had come to see the urologist. I've got a little bit of proteinuria now, but it's nearly 30, how many years will it be? 37 years since I was injured. And all the doctors I go to, they say, how have you survived? You're not supposed to have survived. You should have, according to our statistics, died long ago. And so I said, well, did you have any infections? He said, only for the first 5 years, when I didn't follow your instructions of using the bag. So after 5 years, I went back to using the bag, and after that, I've not had any infections. Now, what is this bag? All of you who, you know what this bag is. You see, these 5 things that I'm talking about avoid over-distension. Jack Lapidus found that if you can, very, very beautifully, that if you can avoid over-distension, then you will keep the defenses of the bladder intact, because over-distension produces ischemia. The blood supply that's coming in through the muscle to the urothelium gets cut off, and the urothelium then becomes weak, and then the organism in the bladder can then walk in. Okay, so over-distension is bad for intermittent catheterization because it produces infections. Then complete emptying is very important. Complete emptying is very important. How can I explain that to you? You remember the story about how a dwarf came to a king, and he asked for a boon. The king said, yes, you can have anything you want. He said, can you give me a grain of rice, 1 grain on the first square of a chessboard, and then double it in every subsequent square. By the time he got to the middle of the board, the king didn't have enough rice to give him. So bacterial doubling time is like that. If you start with 0, it will take a long time for the number of bacteria per cc of urine to get to a critical point when it becomes invasive. So if you don't empty it completely, then you're not starting from the first square in the chessboard, you're starting in the middle of the chessboard. And in a few minutes or few multiplications, the number of bacteria will reach the critical mass. So ensure complete emptying. And it's not easy if you're doing it lying down. It's not easy if you're using a thin catheter, because the urine trickles out and people get impatient, and sometimes the detrusor or the sphincter contracts and the urine stops coming, you think you're emptied. So there are small things like that that are really important for the patient to know. We found that if you there was a lot of discussion what solution to use when you're storing the catheter between catheterizations. Some people use this solution, some people use that solution, and of course our patients told us we can't afford any solutions. So we said, okay, we'll try and dry it. So we told them to put it into into a cloth bag, keep it vertical and dry it. And we found it didn't make much difference. And then suddenly we remembered that the tip of the catheter, beyond the hole through which the urine comes, is a little vessel of urine that is being stored and being put back into the bladder every time. So if you invert the catheter and put it upside down into that cloth bag, it dries. And can bacteria multiply in a dry environment? It can't. So that's how we solve the bacterial count issue. We always tell them to start with a soft catheter, usually a Foley size 18, because remember, we only have one urethra. We have two kidneys, and you don't want to lose any of them. But if you only have one urethra, if you damage your urethra, you get a stricture or something, life is very, very, very difficult. So that's what I tell my patients, and I tell them, use this catheter. I tell them to use a size 18 because I think it's blunter and less likely to produce trauma when they are learning how to do this. Once they've learned well, they can use a Nelaton, which is much cheaper, because we don't have hydrophilic catheters here, sadly, so they still have to use some kind of lubricant. And we give them the 2% lignocaine gel because it's used by anesthetists and lots of other people, so it's relatively inexpensive. So much, I don't have any more time, but if there are questions later, I'll take them. The indwelling catheter risks and benefits, you know. There's an open channel between the urine bag and the kidney, and motile bacteria can swim. So you really have to be very, very careful that there's a constant downstream flow of urine by drinking lots of water when you have an indwelling catheter. And when you switch patients from indwelling catheters to intermittent catheterizations, you tell them you can't drink so much. So we've just convinced them that it's very important to drink very much, and they think we are crazy because last week we told them to drink and this week we're telling them not to drink. But that's the way it is. And of course the suprapubic catheter when it's indicated. With the indwelling catheters, remember that it can cut through the urethra, the penile urethra, so it has to be strapped on the abdomen so that it doesn't do that. The next thing is pharmacological management. I'm just going to rush through this because I don't have much time left. There are antimuscarinics and beta-3 agonists. There are alpha blockers for the bladder, neck, botulinum, and there are very few agents for underactive bladders. We don't have good agents for good pharmacological management for that. Oxybutynin, tolterodine, mirabegron and tamsulosin are all available. I've put the cost there just to let you know that there's not much difference between these drugs. Because tolterodine has a better side effect profile than oxybutynin, but the trospium and the darifenacin, solifenacin is now available in India and almost the same price. So depending on which works best for the patient, you do have a little choice. And I would say that utilize that choice so that you can get the best match for a particular patient. Because for some, the constipation is a big problem. For others, the dryness in the mouth is a big problem. I wish we had transdermal patches and intravesical oxybutynin gel. I just put that in because I wanted you to know that these are available abroad, and I'm sure that they will soon become available for us. Syrup oxybutynin is available, so hopefully we will get those. Those can minimize the side effect because the first pass of going through the abdomen, liver, and producing all the side effects on the brain, on the eye, all those are not there. Recent advances, of course, botulinum toxin to reduce the bladder tone is available in many countries. We are using it much less in our country because of the expense, 25,000 rupees for the botulinum toxin. But the syringe and the appropriate needle is provided by the supplier of the botulinum toxin. I just want to say a little bit about neuromodulation because we've done some work in CMC. Rajdeep, Jacob, Bobina, Dr. Tarian, Suresh published this in 2015 when they stimulated the dorsal nerve of the penis and the posterior tibial nerve and showed that there was a significant drop in the detrusor pressures. And then subsequently, more recently in 2023, they showed that you don't even have to, you can do it, you can neuromodulate the spasticity of the bladder by stimulating the peripheral parts, say, of the medial plantar and lateral plantar nerve on the surface of the foot. And Rajdeep has actually produced a uromodulator, a CMC uromodulator. These aren't yet in production. These are lab models that work. We are now struggling with trying to produce them so that they are inexpensive and available to everybody. The surgical and advanced interventions are just listed for completion. I just wanted to remind you that even at the post-discharge or follow-up phase, you need to take a history and do a clinical exam and maybe do a urine test. You don't need to do any of the others, only unless they're indicated. We are doing the ultrasound because it's inexpensive and non-invasive. So these are the only things that are recommended, and for 30 or 40 years, that's exactly what we have been doing, and that's been now vindicated by other studies. Remember that in your follow-up, you're looking for raised serum creatinine, back pressure changes in the kidney, and of course, increased pressures in the bladder. So I'm nearly out of time. I just want to say that, in summary, remember the neurophysiology, evaluate your patient, plan the management and the follow-up, and remember your goal is not only renal protection, but continence, because together they will give your patient a good quality of life. I've listed a few references for you, and thank you very much.
What's the difference between cystometric volume and infused volume?
So actually, sometimes all the urine in the bag hasn't got into the bladder because it actually leaks out. So I think that's what they mean. The infused volume is slightly different from that. But the detrusor pressure is actually a combination of the abdominal wall pressure and the detrusor pressure. So by the transducer in the bladder is actually giving you a combination of both. So you subtract it from the transducer in the rectum, and then you are subtracting and getting the pressures separately. But the volume is because some of it is not all of it is going to the bladder, and some of it actually leaks out. And so usually we have a flow meter, or it drains into a little balance, and you can calculate by weight how much has got in there. And of course, if he's contracting and leaking out, you call that a reflex void.